to share a few tips about erectile dysfunction, which many of you may have seen your patients in your clinic. Let me share my slides. My topic is on erectile dysfunction and how to choose effective treatment. These are my, I'm a main panel for this medical insurance plan for Singapore. Today, I'm going to talk about a few things. First, how to evaluate erectile dysfunction. Then what are the treatment options? And after that, some of the suggestions I have for GPs in the clinic when you see your patients. We know that erectile dysfunction starts when you must have a proper erection first. So erection is simply loss of blood flow going into the penis, where the corpus cavernosum is filled with blood. And after erection and sexual intercourse, and then the blood flow will leave the penis, and that is a normal process of erection. We also know that erection has to go through the hypothalamus, pituitary, and testicular gonadal axis, where it also affects by hormones. So any hormonal abnormalities may also affect erection. So it's not just the blood flow to the penis, but also the hormones in the body will play a role in normal erection. Hence, in the medical clinic, these are the things we evaluate a patient when they first come to us. Number one, physically, does the male genitalia, are they normal? So we check the prostate, testes, and penis. At the same time, we always check their metabolic issues, including diabetes or cardiovascular risk, knowing that the penis is actually a reservoir for blood flow. The other things we look at is the quality of life of the patient. How is erectile dysfunction affecting their relationships? And the main thing is, what does the patient want? Do you want to have certain erection rigidity or just to have satisfactory relationship? One of the other things we always check is using a validated form, because every man may have a subjective description of their erection. One of the forms we use is called SHIM score. This is an example of SHIM score, which you can download on the internet. It stands for Sexual Health Inventory for Men. It's a simple 5-question survey form for patients, and the total score of the 5 patients, you can already tell them whether they have any erection problem or mild or severe erectile dysfunction. After talking to the patient, we examine the patient. First, we check whether the prostate is enlarged or whether they have tender prostate, which may indicate prostatitis. The penis shape, any deformity, scars, or infection can also be examined. The key thing for us to find out is whether there are hormonal imbalance, which can cause patient to have hypogonadism. So you look for any small testes or absent pubic hair. The other thing we always look for is cardiovascular risk, and we do CVS and neurological examination, looking for peripheral vascular diseases and stroke at the same time. What test do you do for patients when they say they have erection problem? Remember to do a morning total testosterone, and the morning total testosterone should be done between 7 a.m. and 11 a.m. because in our male biology, the normal physiology is that testosterone always go lower after lunch and it goes lower into the night. So if you see a patient at night during your evening clinic and do a testosterone, it will always be low. It doesn't mean they don't have testosterone. It just means that the blood test is taken at the wrong time. So remember, for accuracy, do the testosterone in the morning before 11 o'clock. Other things you may consider is doing fasting glucose and lipids, and also to check for prostate issues with total PSA, especially if your patient is older than 50 years old. What happens when the total testosterone comes back and is less than 12? You will want to repeat it again because you need 2 different sets of studies results to confirm that he really has low total testosterone. At the same time, do a FSH, LH, and prolactin to check for the HPA axis for the hormonal imbalance that may be present in your patient. Why is it important to check the hormones? Because there's a syndrome where we know they have a late onset hypogonadism, where there's a testosterone deficiency. And this is usually associated with patients who also have obesity, type 2 diabetes, cardiovascular disease, metabolic syndrome, and even renal disease or COPD. Just remember, when somebody is diagnosed to have late onset hypogonadism, it is you have to include their symptoms together with a low testosterone. It doesn't mean when someone is tired, when they have low libido, they have less erection, means that they have hypogonadism. No, it's not true. You must have symptom together with an objective measurement of a low morning testosterone. So you can see here, there are a list of sexual symptoms and physical symptoms that indicate a patient may have late onset hypogonadism. So once you diagnose someone with erectile dysfunction, they may or may not have low onset hypogonadism. So how do you decide to treat these patients? For the public, this is exciting when FDA has allowed over-the-counter medication that a patient can simply buy from Shopee, Amazon, or Lazada. You just get this cream, apply on the penis, and you get erection. You don't have to go to a doctor to get Viagra. So this gel has already received FDA approval, which patients are probably buying on the online e-commerce marketplace called Eroxon. But when patients come to Singapore in the medical clinic, these are the options that we have for patients now in Singapore. The most common, of course, is tablets called PDE5 inhibitor. There's a range of them, including Viagra, Cialis, Levitra, and Spidra in Singapore. If the medication oral tablet don't work, we also have intracorporeal injection, where we inject small little needle with the medication into the penis itself for erection. Of course, there are other possibility of putting gel in the penis, vacuum device, or even we can do a surgical implant to put an artificial penis implant into patient for erection. So what's a vacuum device? So most people buy it off the shelf or on the e-commerce website to be sent it to their house directly. This is simply a vacuum erection device where it's a penis pump, where there's a plastic tube that fits over the penis. You can use handheld or battery power to draw air out to create vacuum. Then all the blood will go into the penis and cause erection. There will always be a rubber band at the base of the penis to make sure the erection stays there. But patient must remember to remove the rubber band, the tension ring, within 30 minutes. If not, the penis actually go into pressure, too much tension, and the blood flow doesn't go, and it actually damages the penile structure. So for the medication, I'm sure many of the GP clinics will have one or more of this medication. And these are the list of PDE5 inhibitors tablets that you can find. And they have different profile. Either they can work fast, they can last longer, or they have different bioavailability for patients. So any of this medication actually works for patients. But if you look carefully, the traditional called sildenafil, which is Viagra, has the most studied safety profile. We also know what are the events that patient may have for side effects. For example, sildenafil called Viagra, patients may get headache or flushing and nasal congestion. As compared to many other medicine, each of them have their own side effect profile. As long as you give one of this medication and you know the side effect profile and how it works, it will work for patient. If one tablet don't work, just try another one of the four, and patients will be happy with one of them. So the key important thing is know the medication you are going to give patient. So this is an example of a Viagra, sildenafil. The patient, I always tell them, you must want to have sexual stimulation and take 30 minutes before sex. Why? Because I have patients who come to my clinic and after I give them the medicine, 1 month later come back and say it doesn't work. So I ask the patient, what do you do? What do you mean? Oh, I took the medicine Viagra, then I drink beer and watch your football, but no erection. I say, of course you won't have erection when you don't have sexual stimulation. So you actually must want to have sexual stimulation, then the medication will work. For safety, please try to give the lowest dose if patients are elderly or have kidney or liver problem, and 1 tablet a day. And of course, we know that sildenafil can cause postural hypotension when the blood pressure can drop. So use in caution when patients have nitrates, blood pressure medicine or even taking alpha blockers for enlarged prostate. I tell patients, please don't overdose with Viagra, but if you do have erection longer than 4 hours or painful erection, or you have any side effects that is affecting you, please see A&E doctor immediately. You don't want to have a permanent damage to your penis if there are side effects while you use medicine like Viagra. Very interestingly, now Viagra is not only in the tablet form. Many of you knows that now it comes in a small little film which can dissolve under your tongue or in the mouth. So you actually can carry it in the wallet much easily. You don't have to carry a tablet. So it's simply a film coated dissolvable medication. So these are what are the doses available. Some are lemon flavor, mints, and different country. Korea and Japan, for example, has a film which you just put on the tongue and just dissolve in your tongue. So after treating a patient with erectile dysfunction, you also want to know whether they have any hormonal changes that may be due to late onset hypogonadism. This is an important thing to look for, because if you simply give them the Viagra without looking for hypogonadism, you may not be treating the underlying cause. Some of the treatment, once a patient have hypogonadism, the contraindication treatment is they must not have prostate cancer or breast cancer in men, because there are men who actually have breast cancer. And you also don't give it to patients who have severe BPH or chronic heart failure. They need to also lose weight, increase physical exercises, and you can replace a patient's testosterone because it's low, right? You can replace with any of this medication, either a tablet, gel, transbuccal tablet, nasal gel, is a patch, injection. You can use any of these to replace testosterone in your GP clinic, as long as you monitor them for any potential side effect, make sure they have no cancer, and make sure their hematocrits are being monitored as well. So these are the things you can do in your GP clinic. So after treating ED and after treating them for late onset hypogonadism, we also can try to reduce the chance of erection problem when we treat patient with prostate disease. That's because whenever we treat patient with prostate disease, they can have side effect from medication. For example, finasteride and avodat 5-alpha reductase inhibitor causes erectile dysfunction and ejaculation problems. So we actually cause this by giving them the medicine for treatment of BPH. So many patients who are worried about erectile dysfunction, we actually ask them, do you want to stop the medicine? Instead, do something that can treat your BPH like Urolift, ITIN, or Resume, because these are the treatment that do not cause erectile dysfunction. Some patients who also have prostate cancer and also want to continue to have sexual intercourse, we tell them in the early stage cancer, sometimes you can watch your cancer, no treatment is no side effect. Secondly, they can always try focal therapy to reduce the chance of erectile dysfunction. And thirdly, find a good cancer robotic surgeon to do your radical prostatectomy if your prostate cancer needs a robotic surgery. So let me go through the BPH treatment, which you will see many in your GP clinic. What is Urolift, ITIN, and Resume? Because the patient may want to have this so that they don't have erectile dysfunction from oral medication. Urolift is simply putting in an implant where we actually open up the prostate on the lateral lobe. You can repeat it easily. The procedure actually takes about half an hour. Patients will do this in the morning. They go home at lunch and they can pee immediately, and they don't have to take any more alpha blocker or 5-alpha reductase inhibitor. So this is before and after treatment. You simply open up the lateral lobes of the prostate and you can see directly the urine flow is immediate. You can pee very well. The other possibility is using a ITIN. TIN stands for temporary implanted nitinol device. This is another device that we can use that help to reshape the prostatic urethra. We keep it in about 1 week. No heating, no operation. Procedure takes 5 minutes. Patient go home in the same day. And they have less side effect compared to TURP. So this is how it works. We put the ITIN into the prostate channel A few days later, it will start to expand. In 5 to 7 days time, we take out the metal and the prostate stays open for the patient to pee. And this treatment is about 5 to 7 days. The other treatment we do is called Resume. It uses water vapor, where water vapor goes into the prostate. It's like you cooking, steaming a food in the kitchen. And this is a video of how it works. The scope actually goes into the urethra. When we see the prostate, this is a live surgery picture on the top left-hand corner. We put a needle into the prostate and put steam inside. If you look at it, wait for the needle to go in, and you see how long it takes for each treatment. Now the needle goes in, the steam goes in, there's a counter, and you look in 9 seconds, the treatment is done. Finish. So the treatment is done, patient go home. So it's 9 seconds of treatment to put steam inside. Of course, if the prostate is more enlarged, we put a different area of the prostate. Now you see the picture of the operation going to another area of the prostate, and the needle goes in again. Same thing, another 9 seconds of putting steam in to cook the prostate so that there's an atrophy after some time and the cells will die off. Then there will be an open channel for the prostate. And look at the needle going in. The steam has been delivered, and it's also 9 seconds of treatment. And we are done. So that's how it works for Resume. How about if patients have prostate cancer? In the early stage prostate cancer, some of us may actually do active surveillance, so they have no side effect from erectile dysfunction. But some patients want to have focal therapy. What is focal therapy? Focal therapy means I do not treat the entire prostate. I only treat the area of cancer in the prostate. For example, if you have a watermelon at home and one part of it doesn't look good, do you throw the whole watermelon away? No, you actually dig up the watermelon area that doesn't look so fresh, remove it. The rest, you can still stay there. Same as focal therapy for prostate cancer. Treat only the cancer area. This is a picture of where the cancer may be. If you simply look at diagram A on the top left-hand corner, the prostate outline, and at 5 and 7 o'clock, these are neurovascular bundles which controls erection, nerve, and also continence. And the urethra is in the middle. If the cancer happens to be in one tiny spot in the prostate, why do you take out the whole prostate? Why can't you just treat the cancer area only? So that's what focal therapy does. And we can do the focal therapy on the right side, left side, or the areas with cancer only, just like this diagram. And in Singapore, we already have experience doing these 3 different focal therapy, which is nanoknife, HIFU, and cryotherapy. Let me go through with you. Nanoknife uses electricity to put into the prostate cancer cells so that we use irreversible electroporation. When the electric current goes to the cell membrane opens up, and the cell actually dies because the cell membrane will burst itself and it disrupts the osmotic balance of the patient. Operation is about 1 hour to 2 hours. Day surgery, patient do in the morning, go home for lunch. This is a day surgery procedure. Second thing is a HIFU. We use ultrasound to focus, using a high intensity focus ultrasound to kill off the cancer cells. And this works like a magnifying. If you imagine a magnifying glass that uses sunlight, the pinpoint tip of the magnifying glass will be hot. So the temperature of the pinpoint goes up to 85 degrees Celsius, and that will kill off any cancer cells in its path. The third focal therapy energy we use is cryotherapy, where we use ice balls that goes into the prostate cancer area. Then we freezes it to minus 40 degrees Celsius, warm it up, freeze it, warm it up. So this will cause a disruption to the cell membrane, and the prostate tissues will be destroyed in those areas. So these are some of the examples of focal therapy that we do in Singapore already, so that patients do not need to wear diapers and they do not need to have unnecessary erectile dysfunction. So with that, this coming back to almost to the end of my talk, these are some of the suggestions I have to the GPs for what you may need to do. For example, so this is 2 pages. So first page, part 1 is for history-wise, for patients who have erectile dysfunction, check with them how they feel about their hardness, ejaculation, or satisfaction. Make sure we treat for any UTI or look for BPH symptoms, any pain that may cause that they may have, and anybody who may have metabolic risk like obesity, diabetes, or cardiovascular disease. Don't forget, also look for hormone imbalance. Do they have hypogonadism symptoms? And then what do they really want in the outcome for their erectile dysfunction? For focus exam, we look for patients with enlarged prostate or painful prostate, where there's a BPH or prostatitis, any penis deformity, scars or infection, and any signs of hypogonadism with small testes. And of course, not forgetting cardiovascular examination. And do they have any hypertension, peripheral vascular disease, or stroke? After we have done a proper history and examination, test for morning testosterone. Remember to do it before 11 a.m. to get the accurate total testosterone. Also find out whether they have diabetes or cholesterol, and also PSA if they're older than 50. Please start oral PDE5. Any of the medication will be useful. Monitor for side effect and make sure they don't have hormone imbalance. So when do you refer patients with erectile dysfunction to a specialist urologist? If the patient had tried a few oral PDE5 and doesn't work, then see a urologist. Or secondly, if you find that the penis has some deformity like a pulmonary disease with a lot of scars or pain when they have sex or penis problem, do refer them to your friendly urologist. With that, I just want to come to the end of my talk where I talk about smile. I tell patients, I know you have erectile dysfunction, but are there things that will make you happy? And my suggestion is maybe look at ways to improve your self-care, make friends, have inner peace, love others, and exercise. Sometimes all these, suddenly the erectile dysfunction problem doesn't seem so big anymore, and they are happier, and hopefully all your patients are happy and cheerful. We know that there are a lot of psychological effects when they have erectile dysfunction, and also many other medical issues to think about. So my friends and I, we started this program called Dr. Hughes, where we run a program, a wellness retreat in Chiang Mai, Thailand, to reduce stress and reduce burnout. We work with groups of medical doctors and also wellness experts in Chiang Mai. So have a look at drhughes.com and see whether this helps your patients or whether you can tell their family members as well. In addition, we also don't like to have fake medical news. You know, some of the patients come to you having read in Google or Facebook about certain medical condition. We don't like fake news. So we also started Asia medical doctor website called asiamd.com to give them healthcare articles, wellness tips, and health tips. And it's also in English and Mandarin for many of our Mandarin patients. So these are some of the social channel, media channel that they can follow. And we are also running this CME Talk. We also will run webinars for public soon. And also e-magazine for any of your patients. Just sign up anytime. So with that, I thank you and I'm happy to have any questions. Thank you very much and God bless. If you need my slides, just email me. I can send you a copy of the PDF. This is my email at tiantai.chong@surgi10.com. And I see patients in Surgi-TEN Specialists. Thank you very much for your time. Thank you for your question. Anybody who is, no matter what age, if they have a low testosterone first, I will check the FSH, LH, and prolactin to find out what are the other possible factors, whether it's a testicular failure, whether it's a pituitary tumor that can cause prolactin, or any of the HPA axis that's abnormal. So no matter what age group they are, I first make sure their testosterone is taken at the correct time. Please take before 11 a.m. because if you take after that, it's not accurate. So repeat it again. If you get 2 times of abnormal testosterone in the morning, then do the rest of the hormone profile. Any abnormality, I sometimes just refer them to the endocrine to work out, are there additional hormonal imbalance? Revascularization is one of the treatment that some of the andrology doctors do. I don't have a good experience in it. I know that in some of my colleagues and friends in Thailand or other countries do it. Uh, and then the data doesn't confirm it will 100% work. But one interesting thing we know is that the whole penis is actually an empty reservoir for you to wait for blood to come in for action. So that's why anybody who doesn't have good erection, we always say, hey, do you want to check your heart or other blood vessel? Because the artery and the blood vessels to the penis is smaller than the coronary artery. So if somebody have erectile dysfunction, maybe a few years later, they may start to have heart attack or coronary artery disease. So this is the narrowing of a penile blood vessel first before the bigger vessels are blocked. So to me, I know this is one option. I don't have experience whether it's 100% effective. At the moment, this is not a standard of care for erectile dysfunction treatment. That's a good question, whether we need to wait for all the blood results or tests. No, you don't have to, because Viagra will also help patients no matter what is the diagnosis. But if they have hormonal abnormality, you want to treat that at the same time. So it's okay to get a Viagra or medication to start. You get the treatment first. When the result come back, then discuss whether there's any hormonal things you need to work out. But more importantly, also check out metabolic disease. Some of the patients actually come to you and they have undiagnosed cardiovascular disease, undiagnosed diabetes, and this is the thing that at the same time as a family physician, you can look after their health. So every drug company says, please take theirs only and don't take other people. So I know there are some patients who take Cialis 5 milligram daily because of BPH and ED. There's no standard guideline whether you can take someone else, but our general sort of official guideline is follow the drug company's advice, don't mix. I know some GPs or doctors who actually add additional, but it will not be an official recommendation. Because Cialis is also used for BPH and ED at the same time. Our worry has always been postural hypotension, where the blood pressure drops, patient get into side effect, which is a known side effect if you mix Cialis.